The following podcast is part of a certified educational activity titled On Target, Integrating Trop-2-Directed Therapeutics for Urothelial Carcinoma with Precision. Access the entire activity and complete the post-test at peerview.com/ZDU860. Downloadable slides and practice aids are also available.
Hello, everybody. I'm Dr. Petrus Grivas. I'm a professor at University of Washington for Hudson Cancer Center. I'm serving as the clinical director of the GU Cancers program here in Seattle, Washington. And I'm very excited to present to you and welcome you in this educational activity with the title On Target, Integrating Trop-2-Directed Therapeutics for Advanced Urothelial Carcinoma. Here, in a series of educational modules, we're going to explore exciting developments supporting the use of Trop-2-directed strategies for patients with urothelial carcinoma and try to equip you with approaches to effectively implement management plans and provide useful guidance on safety and patient educations. As you see, I'm wearing the Bladder Cancer Advocacy Network t-shirt today. It's important to raise awareness about bladder cancer in the broader community. The Bladder Cancer Advocacy Network, BCAN, is a great resource for our patients, caregivers, providers, and the broader community, supporting this need for education, research, optimal patient care delivery, advocacy, and help us taking care of our patients with all those resources. So I want to help in that effort of raising awareness. And BCAN has a website that patients can refer to and connect with other patients, have printout materials, have online resources. So before we start this activity, let's hear more about this unique format we're going to use today.
Find out how much you know about optimal management of bladder cancer through a simple 3-step process in this self-assessment activity comprising 5 question modules. First, answer the baseline question to evaluate your knowledge and skills. Next, review the supporting evidence shared by Dr. Petros Grivas. Finally, answer the question again to demonstrate what you've learned. Each correct answer automatically counts toward post-test completion, which means that getting your CME credit is fast and easy.
Okay, let's talk a little bit about the need to address unmet needs for treating metastatic urothelial cancer and how we can do this in an optimal way to serve our patients. Obviously, there can be shortcomings in the real-world management of this challenging disease, and our job as providers in a team is to try to address those challenges and create more opportunities for improvement for our patients and for our teams, of course. As you see in the left part of the slide, about a quarter to a half of the patients may not receive treatment for this disease historically. And we're hoping and believing we're changing this by having more therapy options available to our patients, reducing disparities, eliminating disparities in cancer care and access to care, creating more therapy options through innovative clinical trials, and of course, having more availability in best supportive care, palliative care, integrative medicine, and other best supportive care techniques, physical therapy, occupational therapy, nutrition support to help more patients get effective and safe therapies to help them live longer, improve their longevity, and also help with their quality of life. As you see also on the left part of the slide, post-immunotherapy therapy options may include other chemotherapy options. And of course, we have now the development of antibody drug conjugates, as well as one targeted therapy against FGFR, fibroblast growth factor receptor. So we have more options for our patients. That's why I think we're improving upon the proportion of patients who actually can get therapies and stay in the wagon of therapy. Here, as you see in that slide, there have been studies looking at real-world data. And on that slide, you see a study that was presented in the past looking at real-world therapy patterns, healthcare resource utilization, and economic financial burden among patients who are Medicare beneficiaries with advanced urothelial carcinoma after progression of checkpoint inhibition. As you see in that particular slide, this was a study that looked at the significant number of patients. And as you see on the right part of the slide, of approximately 800 patients who had received checkpoint inhibitor before and discontinued therapy, you see that about 26 received a different checkpoint inhibitor, again, despite the lack of robust data there. A significant proportion got chemotherapy, but a large number of them did not receive more treatment. So definitely there is a need for education to the broader community to choose the right therapy for the right patient at the right time, based on the wealth of new data now with, again, as I mentioned, antibody drug conjugate and FGFR inhibition. And obviously, it's very important to have effective communication among multidisciplinary teams. Education of patients is key regarding management of and timely recognition of adverse events. Encourage patients to report adverse events and to avoid underreporting. Train our advanced practice providers, nurses, and pharmacists to properly triage patients. Maintain connections between the clinical departments and different components and members of the multidisciplinary team. Establish a point of contact for patients to navigate and guide these discussions. And of course, having great collaborations with other subspecialties outside oncology, dermatology, GI, pulmonology, cardiology, etc., to help management, especially those adverse events that may happen. And the Bladder Cancer Advocacy Network is a great resource for patients, has educational material, printouts, website, a phone number, email, a hotline that patients can call and connect with survivors, with other patients. So really a shout out and kudos to Bladder Cancer Advocacy Network for creating these resources for professionals, for providers, for patients and caregivers to help our patients navigate through treatment and also support clinical research and education for patients. Let's talk a little bit more about Trop-2 as an ideal target for bladder cancer therapy. Trop-2 gene expression measured by mRNA seems to be present across tumor types, a variety of tumors, and I think that's a very important data set from the Cancer Genome Atlas project. And you see that there is significant expression specifically in urothelial carcinoma, also in breast cancer. And I think this drove the drug development with antibody drug conjugate against Trop-2 initially in these tumor types, breast cancer and urothelial carcinoma. As you see, the protein of Trop-2 is significantly expressed across different subtypes, of bladder cancer, and that's important. That was a study in Johns Hopkins and also a study at the University of Washington Fair Hats, looking at Trop-2 as a target across different bladder cancer histology subtypes. We used to call them variants, and maybe with the exception of neuroendocrine subtype. And this actually setting the stage for clinical trials, looking at evaluating anti-Trop-2 ADCs in different histology variants, subtypes, and we're doing those trials to try to evaluate safety and efficacy of anti-Trop-2 ADCs in these histology variants. The mechanism of action of antibody drug conjugates, as you see, it's a Trojan horse approach. And what you see there is an antibody that tries to bind to a particular target. And this interaction leads to the payload-independent anti-tumor activity via several mechanisms. For example, an Fc-mediated stimulation of immune cells and immune stimulation, disruption of receptor dimerization. Of course, the main goal of antibody drug conjugate is to conjugate a toxic chemotherapy payload and bring them into the cancer cell as specific as possible. So there is an internalization that happens after of the antibody binding to the target, and the chemotherapy payload gets internalized into endosomes and lysosomes, and this release of that chemotherapy payload may result in cancer cell death, and obviously these payloads may potentially get diffused after a cancer cell die, or even through bystander effect may also get diffused in the tumor microenvironment and may result in cancer cell killing. Here, specifically, we have an antibody drug conjugate targeting Trop-2. A couple of examples on the left, sacituzumab govitecan. You see that that molecule has an anti-Trop-2 antibody and is a linker that links this drug with SN38, a very active metabolite of irinotecan, a topoisomerase 1 inhibitor with a high drug-to-antibody ratio. And you see on the right that datopotamab deruxtecan a different antibody drug conjugate against Trop-2. There, the payload is the deruxtecan is another topoisomerase 1 inhibitor. So similar, with a govitecan, a little bit different molecule, and you see here a little bit more moderate drug to antibody ratio, 4:1. And of course, we have been seeing data with these antibody drug conjugates in clinical trials, and the role of drug to antibody ratio is still remains under evaluation in different trials and try to optimize, of course, the delivery of those molecules and the structure in the tumor microenvironment. And here is the sacituzumab govitecan in more detail. I will focus the attention on the right part of the slide. You see that we have already approvals in 2 cancer types, in metastatic triple negative breast cancer, at least 2 prior therapies, and also there is an approval more recently to, if I remember, ER positive, HER2 negative metastatic breast cancer. So 2 indications in breast cancer. Of course, we have the accelerated approval of this drug in metastatic urothelial carcinoma in patients who have progression after platinum-based chemotherapy and after checkpoint inhibition, based on the data from the TROPHY-U01 cohort 1 trial. Let's talk now a little bit more about these Trop-2 targeted approaches, specifically in advanced urothelial carcinoma. As I mentioned before, TROPHY-U01 is a multi-cohort phase 2 clinical trial that looks at sacituzumab govitecan, then at Trop-2 ADC, in different therapy settings, and also either alone or in combination with compounds. I will focus your attention in cohort 1, the higher up in the left upper corner, that evaluated sacituzumab govitecan, let's call it SG, in patients after prior platinum-based chemotherapy, after checkpoint inhibition. So this was 3rd line or later lines of therapy. Many patients were heavily pretreated. We're going to see the data in a second. Cohort 2 evaluated SG as monotherapy after checkpoint inhibitor. So 2nd line cisplatin ineligible patients, some of them were platinum ineligible, and they got SG alone after checkpoint inhibition. The data were presented from cohort 2 in prior meetings and are being published very soon in a prestigious journal. Cohort 3 was also just published at Journal of Clinical Oncology, and we presented the data with such SG combined with pembrolizumab. That was a combination tested in cohort 3. This is a population of platinum refractory patients who had early progression on platinum, many of them, and they got SG plus pembro combination, and that showed a 41% response rate in the 2nd line setting, setting the stage for a new phase 3 trial that will launch in the near future, looking at sacituzumab govitecan plus pembro versus sacituzumab govitecan alone in patients with prior immunotherapy and or prior therapies. We're very excited about that future trial. Cohort 4, 5, and 6 are ongoing and are evaluating sacituzumab govitecan in the frontline setting, usually in combinations with other agents. As I mentioned before, sacituzumab govitecan received accelerated FDA approval for patients with metastatic urothelial carcinoma after prior chemotherapy with platinum and after checkpoint inhibition. This happened in 2021, and this agent has been approved since then. Again, accelerated approval and has been used in the United States for patients in that particular setting. As I mentioned before, cohort 1 specifically looked at sacituzumab govitecan single agent after chemotherapy, after checkpoint inhibitor. In that cohort, many patients had many prior lines of therapy. They were heavily pretreated, and the median number of prior therapies may have been 3, but the range was anything between 1 or 8 prior lines of therapy. So heavily pretreated patient population. And you see in the waterfall plot on the left that most patients, about 3/4, had reduction in the tumor burden. And on the right upper corner, you see the overall response rate was 28%. Median duration of response exceeded 8 months. Median PFS more than 5 months, and median overall survival approximately 11 months. This was a single arm not randomized trial, so we take the PFS and OS with grain of salt, but definitely very promising data there in terms of survival. And of course, based on this response rate and the durability of response, the FDA provided accelerated approval, as I mentioned, in 2021. On the lower part of the slide, you see the spider plot on the left lower corner and the swimmer's plot on the right lower corner. You see that many of those responses could be durable, and that's what we hope for our patients. So in a select patient population, you may see durable responses. Of course, we lack biomarkers to try to predict who those patients are. And this is a confirmatory phase 3 trial called TROPiCS-04. This is to confirm the cohort 1 of TROPHY-U01, the previous phase 2 trial. And this takes SG at the standard dose, at initial dose, 10 milligram per kilogram given on day 1 and 8 on a 21-day cycle. The same dosing and the same schedule that was tested in the TROPHY-U01 trial. And this is compared head-to-head to either taxane in the US, onvinfulin in Europe, and this treatment continues until progression or unacceptable toxicity. The primary endpoint is overall survival, and we'll also look at progression-free survival, response rate, and quality of life metrics, patient-reported outcomes. This trial has complete accrual, and we're waiting for the results in the very near future. And this cohort 2, I mentioned before, this was already presented by Dr. Petrylak and our team, and it's going to be published very, very soon in a prestigious journal. Cohort 2 took patients who were refractory to checkpoint inhibitor first line. These patients were cisplatin ineligible. Many of them were platinum ineligible, and they got SG monotherapy in the second line setting. Response rate was 32%. Median duration of response a little bit more than 7 months. Median PFS and OS, you see 5.6 and 13.5 months respectively. You see the waterfall plot on the left lower corner and the swimmer's plot on the right. You see most of those responses are rapid responses, occur early on, and a significant proportion of patients have a reduction in the tumor burden, and this again confirms the activity of this agent post checkpoint inhibition. Cohort 3, as I mentioned before, it combines sacituzumab govitecan plus pembrolizumab. This is platinum refractory disease, immunotherapy naive in a second line setting. 41 patients, a phase 2 single arm study, and it showed, I would say, a very promising 41% response rate. Half of them were complete responses, about 20%. Median duration of response about 11 months. Promising signal in the median PFS and median OS, and you see in the spider plot on the right upper corner that some of those responses were durable. So we think that the addition of pembro provides higher response rate and more deeper responses and more durable responses. So we're going to test this combination. You see the waterfall plot in the right lower corner, and we're going to take this combination and test it in a phase 3 trial, which is shown here. I mentioned it before. This is patients who had prior immunotherapy. This is necessary, mandatory prior immunotherapy. Patients may or not have received prior platinum-based chemo or enfortumab vedotin. This is allowed, and patients may have had up to 2 or 3 prior lines of therapy for metastatic urothelial carcinoma, and they got randomized to SG plus pembro versus SG alone. Primary endpoint will be overall survival with a plethora of secondary endpoints and correlative biomarkers. This trial is expected to open in probably Q4 2024. We're looking forward to it, and hopefully you can open the trial in your site if possible. Let's talk a little bit about understanding further the dosing and safety considerations of Trop-2-directed antibody drug conjugates. And I think that's an important practical parameter in the daily practice of patients. And I would say that antibody drug conjugates have a unique set of adverse events, and that's important to keep in mind. Sacituzumab govitecan, for example, it can cause, fatigue, nausea, low appetite, taste changes, alopecia. But the more common adverse events are usually neutropenia and diarrhea. Neutropenia is usually managed with primary prophylaxis with growth factor, GCSF. And I think the introduction of GCSF early on as primary prophylaxis significantly can reduce the chance of neutropenic fever and sepsis, and is strongly recommended in our patients. And diarrhea is usually mild to moderate, usually happens a few days after the drug administration, and is usually managed well with anti-diarrhea medication. difenoxylate, loperamide, and sometimes, occasionally, hydration can be of help in patients. We encourage them to be very well hydrated at home, orally, and occasionally with IV hydration. So that's very important. And sometimes we may check electrolytes, of course, in those patients if they have notable diarrhea. The topotomab deruxtecan, it have a little bit unique adverse events to look for: stomatitis, ocular toxicities, eye issues, and ILD, interstitial lung disease, something to keep in mind. We have seen similar ILD with trastuzumab deruxtecan, a different ADC against HER2. So maybe the deruxtecan compound may be relevant, but I think it's important overall to educate the patients about the totality of possible adverse events, give them educational material, do teaching in clinic with a nursing team or pharmacist, and of course the provider for proper discussion and education and proper recognition and timely reporting of adverse events. Here you see that safety consideration are important. Also, in terms of infusion reactions, monoclonal antibodies could result in infusion-related reactions. Grade 3 or 4 are very rare, I would say, but could occur. So it's important for each cancer center to have hypersensitivity reaction protocols and have guidance to the providers and nurses how to manage those if they happen. And usually they observe within 24 hours for administration of such govitecan. Usually mild to moderate, rarely can be more severe. And this is leading to the discussion about discussion with the pharmacist, and each cancer center may develop their own protocol when they develop the guidelines in management and how to prevent and treat those reactions. Considerations are given to pre-medications with pre-meds like H1 and H2 blockers before infusions, and that's a discussion again with the pharmacist. And of course, as I mentioned, different institutions have different protocols. When you place these orders into the electronic medical record, discussion with the pharmacist is key. How to build these orders, what medications, pre-meds you choose to give, and of course, what is the guidance for management for any potential, if they happen, infusion-related reaction. And of course, monitoring patients is important during the infusion and at least half an hour after the end of the infusion. Here, I want to highlight again some of the adverse events that may happen with sacituzumab govitecan, the anti-Trop-2 ADC. The payload is SN38 and very active and potent metabolite of irinotecan, a topoisomerase 1 inhibitor. So the side effect profile is not a surprise. We mentioned before the neutropenia, and I strongly recommend growth factor support as primary prophylaxis. And if needed down the road, those reductions or those halts, delays may be needed case by case. Although with the use of growth factor, we have seen lower need to dose reduce because you have less neutropenia and less chance of neutropenic fever. And this is consistent also with the ASCO guidelines based on the demographics of those patients and prior therapies. And as I mentioned, diarrhea, education is key, hydration with electrolytes, orally at home, occasionally intravenously, and under diarrhea medication, best supportive care. And of course, to make sure you don't miss any other diagnosis like an infection. So sometimes we do stool cultures and other workup as needed for patients case by case. After we reviewed these important data sets, I think it's important to remind ourselves to educate the patients well in a detailed, careful, thoughtful, and balanced way regarding how antibody-drug conjugates work compared to other treatment modalities. A detailed and balanced communication is key for preparing patients to recognize adverse events early, report in a timely manner, and of course help us mitigate toxicities effectively. An informed and shared decision making is very important and should be used in creating individualized therapy plans. Now, let's have a look at how this can be accomplished via telemedicine approach. Obviously, for educational purposes, this is a trimmed and condensed telemedicine approach just to cover some key points with a provider-patient interaction. We're going to discuss a patient. His name is Calvin. He's 67 years old. He has metastatic urothelial carcinoma with lung nodules and lymph nodes. He's a retired teacher. He's married with 5 grandkids, and he wants to be actively engaged in activities with his grandkids, sports recitals. So, how can we help his quality of life and his functionality to be able to attend those is a priority for this patient. He likes to garden and take walks in the neighborhood. Overall, he is eager to get this disease under control, but of course, he's worried about starting another therapy, changing therapies. He's in overall good health, however, has significant neuropathy in both hands and feet, and this has impacted the way of daily walks, his ability to button, search, and tying shoelaces and do gardening. He has to grab a rail when he's in the shower to avoid falling. So a grade 2 neuropathy impacting some of his daily activities, indeed. And also he has history of diabetes mellitus, and a recent check showed a hemoglobin A1C of 9, which is a high number, and he was definitely referred back to his primary care provider and an endocrinologist for optimal control of the diabetes. And we discussed with that patient the need to control diabetes overall for his health will be a good thing, but also specifically this can help optimize his status for future therapy options, in particularly for urothelial carcinoma. So it's a good opportunity to discuss with patients and partner with primary care and other specialists, for example endocrinologists, in that regard, for optimal discussion of those other medical conditions. These particular patients had already received induction chemotherapy with gemcitabine cisplatin, followed by switch maintenance avelumab, and that patient was followed with a local medical oncologist. Recently, the patient had progression of the urothelial cancer, and because of the long distance involved, he reached out to our tertiary center for a telemedicine appointment to help guide discussion for future therapy options. And we're going to have this snippet and condensed telemedicine as an example of how we may interact with patients for this particular scenario. So I'm going to start this educational mode. And I will welcome Calvin. Calvin, thanks for joining me today. Thanks for reaching out to me. Let me ask you, how are you feeling? I read all your records and I familiarized myself with the situation. Thank you so much for reaching out to me. May I ask how things are going for you? How are you feeling day to day?
Uh, I, I'm doing all right. It's it's been getting used to. I still have a bit of floppy foot when I go to walk. And using my hands in small motor. It's very difficult, but I'm getting along. I'm feeling better. Um,
Thanks, thanks, Calvin, for sharing with me. And obviously, your quality of life is very important. I know you have been working very closely and very well with your local medical oncologist, and you have done your part very well. And I want to ask you, how are you recovering from that treatment? Are those previous side effects getting better?
yeah, things are getting better. You gave me some. Well, the local oncologist gave me some drugs to handle the side effects, and I've been doing better. Doing better. I'm interested in this new process you're working on.
Thanks, Calvin, for sharing with me. It's important to understand exactly how you're doing. And in terms of this new treatment therapy that we're discussing, taking into account, the neuropathy that you have been having, the diabetes, and I know you're working with your primary care physician and endocrinologist to optimize that because it's good for your health and also for potential other future therapy options for you. So let me tell you a little bit about this new therapy that your local oncologist and me have talked about. It's a new treatment that is it's a chemotherapy that is targeted to the cancer cells. So you think about it, Calvin, as a Trojan horse approach
Mhm.
that we try to package the chemotherapy and send it, if possible, through the vein. The treatment is given intravenously through either a peripheral line or a port if you have, and tries to go as possible to the cancer cells. It's kind of a packaged targeted chemotherapy, the way I call
Yeah,
it.
It's so it targets. It's very targeted, very direct.
That's the intent.
Just like chemo. I mean, this is how's this going to affect me? I still like to get out and walk, and can I travel, see my granddaughter's piano recital or something? You know. Um,
It's a great question, Calvin. Thank you for asking this. This treatment can have side effects like everything we do in oncology, to your point. Most common side effects may include fatigue. People may feel tired some days, usually mild to moderate. Many patients are able to attend their daily activities. Our hope is that by controlling the cancer and managing the side effects, hopefully you will be able to attend your grandkids in their soccer games and other activities you like. I think it's important to try to prevent infections with that treatment. So we
mhm.
can talk a little bit about some medications that we may give you, the local oncology will give you to reduce the chance of infection,
Yeah.
and also to manage potential nausea and diarrhea that may happen with this medication. Some people may lose their hair to a degree, so you may notice that, and also will keep an eye on your appetite and taste as well.
Okay. Okay. Can I get in touch with you personally later on? Later in the week, later in the day. And is there anybody I can call to get some kind of help or support with this new technology?
You are very happy to help, Calvin. We have a great team here of nurses, advanced practice providers, pharmacists, etc. Feel free to send us a message in a my chart method in the medical record, or through a phone. Your local medical oncologist will be able to manage day-to-day details and nuances of your treatment. But I want to also be available to you as a resource and to your local oncologist as well, in terms of managing side effects, potential dose adjustments, and of course, if no good, if there is any cancer progression in the future, to help guide potential future therapy options. So keep us posted, both you and your local medical oncologist, and I will call him to discuss with him directly about the nuances of treatment and this prophylactic or preventive injection that I would recommend to boost up your white blood cells, to prevent, if possible, infections, and also some anti-nausea and anti-diarrhea medications.
Okay. Okay. Well, thank you. Thank you very much. I appreciate the support and the help you folks have given me.
Thank you, and I hope you have benefit from the treatment with impact in your longevity and also your quality of life. And please keep us posted, Calvin.
Will do, sir. Thank you very much, Dr. Grievous.
Thank you. Hello, Calvin. It's great to see you back. I know we met about 3 months ago when you were contemplating the treatment options in this case. I know after discussion with your local medical oncologist, you opted for this antibody drug conjugate called sacituzumab govitecan. This was given on a day 1 and day 8 on a 21-day cycle, and your local doctor gave you also this growth factor, we call it, to boost up your white blood cells, and also some anti-nausea, anti-diarrhea medications if needed. Let me ask you how things were going for you, and how have you been doing with this treatment?
Oh, just well. Thanks, Dr. Grievous. Yeah, it's been a while. At first, I was feeling really tired and you know suffering from diarrhea. So, but I got some anti-diarrhea meds. They seem to be working. I'm trying to stay hydrated. That helps. My granddaughter gave me a fancy little water bottle, but I'm usually tired for the rest of the day and somewhat the next day after the treatments. But I'm keeping up otherwise. I started a garden, and the wife and I have met with people through a support network, and it's all working out. It's all working out.
That's fantastic, and I love the idea of the water bottle that your granddaughter gave you. I know the family has been very supportive of you,
Yeah.
and I'm glad to hear that the diarrhea is getting under control. The fatigue seems to be controlled. Any major issue with nausea, or you're doing pretty well with that part?
No, this particular line of treatment, there wasn't the nausea that I had suffered from before. So that's a good thing. That's good.
That's wonderful. And I hear, Calvin, that you're getting involved with the Bladder Cancer Advocacy Network, and you plan to do some activities. And I know there is a recent bladder cancer walk event that you have been trying to participate.
Yes, we've been doing all kinds of activities, and it's a great support network. The Bladder Cancer Network. It's been great.
Wonderful, wonderful, and it's great. And this treatment, as we discussed in the past, usually keeps going with potential dose adjustments if needed. The dose adjustments may require reduction or holding the dose, depending on side effects that may happen in the future. And your local medical oncologist has discussed with him in detail, and is looking to that, is monitoring you closely. And sometimes those reductions may need to happen, but as long as you're doing well, you tolerate the treatment reasonably well with no significant side effects, and as long as the cancer does not grow, stays stable, or shrinks, usually the treatment keeps going as long as you derive benefit from it.
Good, because that'll be good as long as we can maintain the good.
Wonderful. It's always a balance with quantity of life, longer life. It's our goal, and also quality of life. So pleased to see you again, and please keep us posted in the future how can be of help. I will give a call to your local medical oncologist as well.
Okay. Thank you, Dr. Krivas. Appreciate it.
Thank you, and great to see you.
Good to see you, sir.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit at peerview.com/ZDU860. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the Bladder Cancer Advocacy Network. This activity has been supported by an independent educational grant from Gilead Sciences, Incorporated.